Morning, Drew.
Good morning.
First round of the years for you, huh?
Yeah.
You had lots of time to prepare, so that's good.
Yeah. Yeah, it came up quick after Chief. I was making sure everything was in order. I was like, oh, goodness. I guess I've got a grand rounds to set up.
And when are the exams this year? Same time as last, or in the new time?
No, they're starting the shift now. So we do, it's either beginning of March, end of May, or end of March, beginning of May. Something like that. March is the multiple choice, and then May is the OSCE.
Gotcha.
Yeah.
Good.
It's coming up soon too.
We'll give everybody another minute to check in. We were hoping that we'd be having some of these in person by now.
Did you get your vaccine passport yesterday? The site opened up and was crashing with huge wait times and everything.
Oh, is that right? No, I haven't got it yet. I'll have to do that. Is there a link for it?
Yeah, it was on the Vancouver Sun website. I just clicked the link and it said there was a 65-minute wait time or something. So it'll probably get better over the next few days. But
or you do it in the middle of the night?
Yeah, true.
Well, let's get started then, Drew.
Sure.
Good morning, everybody, and welcome to the 2021-22 academic year. A couple of announcements just to start the year off. Wanted to welcome our new fellows and new residents, 3 new residents, Anna Black, Ryan Yan, and Ghislaine Musa. Welcome to your first weekly rounds. Also to Andrew Strawn from Australia, George Auckland from New Zealand as the Uro-Onc Fellows. And I think we have a new pediatrics fellow, Christina, but I don't know her last name. So we'll look forward to meeting you throughout the year. There is also good news just around some awards coming into the department over the summer to prestigious Canada research chairs. These are the most eminent academic chairs held by scientists in the country. And urology was awarded 2 to Amina Zubeidi, who is a professor at the Department of Urologic Sciences. And hers is in tumor plasticity, a CRC in tumor plasticity. And also to Art Cherkasov for his work in computer augmented drug design. So again, 2 highly prestigious chairs into urology. Congratulations, Amina and Art. So with that, I'd like to hand it over to Drew Phillips, who's PGY5, and is going to talk to us about partial approaches to partial nephrectomy. So Drew, over to you.
All right, thanks so much. So yeah, I thought I'd do the first grand rounds on surgical approaches to partial nephrectomy. And we see throughout our training so many different variations on the same basic principle to get the tumor out while leaving a good kidney behind. And we're exposed to so many different techniques. And I figured why not take a dive into what the evidence shows for what actually is best and determine once and for all who does it best or what, as the case may be. There we go. So we're going to talk about different surgical approaches to nephron-sparing surgery and the outcomes for each, as well as discuss different components of the surgery itself to determine the evidence behind these different components and steps for what provides the best outcomes for our patients, and then look to the future and talk about some prospective things that may benefit the operation moving forward. I have no disclosures. So the first partial nephrectomy ever performed was in 1867 by a guy named Spiegelberg. He unintentionally removed half of a kidney while he was doing an operation for removing liver cysts. The patient ultimately died, but this did kind of show that you can cut out part of a kidney, or at least think about doing that. It wasn't until 1870, a few years later, when Dr. Simon did the first intentional partial nephrectomy for a patient who had hydronephrosis, and this patient did survive. The first partial nephrectomy for malignancy was in 1887, so almost 20 years later, by a guy named Cerny, and Cerny's down on the bottom there. This was for, I think it was an angiosarcoma. The main issues for not taking this procedure up at this time was bad sepsis in kind of every post-operative patient, as well as intraoperative bleeding, delayed bleeding, and fistulae, same as the complications we see these days, but the understanding for techniques to manage this wasn't as well understood. So it really started to take off once aseptic technique became discovered. It used to be thought that a contraindication to partial nephrectomy was having a normal contralateral kidney, and this was looked at in kind of animal studies where they'd remove a kidney or both kidneys and see how the animals did. They figured that if you have a normal contralateral kidney, then what's the point of saving an entire kidney if there is a tumor in it? This led to a preponderance for subcostal incisions being the mainstay that surgeons would use so that they could physically assess both kidneys, just so that they could manually palpate for any nodularity or concerns with the contralateral side, as imaging wasn't very good at that time. It really wasn't until 1975 or so when Wickham reported a 5-year survival rate of 72% with recurrence rates similar to radical nephrectomies that this really started to take off as a mainstay in the urologic armamentarium. Just as reference points, laparoscopic surgery came into vogue in urology with the first lap nephrectomy in 1991, so really not that long ago, and then the first lap partial in 1993 by Winfield in Iowa. Some of the key outcomes that you'll see in studies for partial nephrectomy is mainly, the usual things we look at in post-op surgery. So preservation of nephrons, what their renal function does post-operatively, what the margin status is, warm ischemia time, complication rates, recurrence rates, overall survival at time of OR and time of admission, blood loss, and cost of this operation. So there's multiple variables that can be assessed within one operation. In these studies that are out there, you may hear the term trifecta thrown around. This is commonly thought to be in a partial nephrectomy, no intraoperative complications, having minimal reduction in GFR, and achieving negative margins. This is kind of the three things that you really want to see in a partial nephrectomy. But variations within this definition exist. So I won't focus too much on achieving the trifecta, but rather looking at straight outcomes to compare techniques. So in terms of approaches, open versus minimally invasive, so laparoscopic or robotic partial nephrectomy is a meta-analysis. This was a NISQIP database harvest of data back in 2018, where they looked at almost 14,000 patients from 2010 to 2015. 34% of these patients had open partial nephrectomies and 66% had MIS. Overall, healthier patients were in the MIS group, as this was just retrospective, and there was no mention of tumor characteristics, size, or complexity scores. Overall, this study showed that Basically, every metric that they looked at had significant difference between open and laparoscopic surgery in postoperative complications and blood loss, reoperation rates, and 30-day mortality. But it wasn't really a fair fight, as it wasn't randomized. There was no control for tumor characteristics, and it was just a retrospective analysis. So to even up the playing field, a meta-analysis was done in 2020, looking at laparoscopic versus open surgery, and what the outcomes, surgical and functional outcomes, was of this operation. It included 26 studies, just over 8,000 patients, and 6 of the 26 studies were prospective. There was no difference in operative time or intraoperative complications between the two groups, and it did favor laparoscopic partial nephrectomy in terms of blood loss, transfusion rates, length of stay, total complications, and postoperative complications. In terms of oncologic outcomes, the meta-analysis did show a favor towards open partial nephrectomy for surgical margins and overall survival, and a subgroup analysis for T1A tumors, so that's both in the open and MIS category, negated the advantage for margins for open surgery. There was no difference in disease-free survival or cancer-specific survival, though. In terms of functional outcomes, there was no difference in the change in serum creatinine or EGFR. So what about robot versus laparoscopic or open? This was a case series from Toronto. They looked at 110 robotic surgeries, 70 laparoscopic, and 73 open. This was kind of a time-wise progression from open towards robotic from 2005 up to 2016. And they said there was no differences in the preoperative variables amongst all groups. Overall, this is just a slide showing the preoperative characteristics with no statistical significant difference amongst all 3 groups. This one here shows the operative data stratified according to the different surgical approach. So you can see that, my highlights didn't come through here, but warm ischemic time and operative time favored open partial nephrectomy over robotic, and also for laparoscopic over robotic. For those 2 metrics, no difference in blood loss or postoperative hemoglobin, and the postoperative creatinine seemed to favor laparoscopic over robotic. Hospital stay was obviously shorter for the MIS surgery for robotic versus open, and for robotic over laparoscopic as well.
Drew, can I interrupt you for a second?
Sure.
How can you explain a shorter warm ischemia time for lap versus robotic?
I'm not sure.
Must be patient selection, would be my point.
Yeah, in their preoperative metrics, they said there's no difference between the complexity scores amongst the 3 groups. But yeah, I agree. Who knows if it's surgeon skill over the course of those 5 to 10 years that they looked at, whether they transitioned from laparoscopic to robotic, whether or not they were more comfortable with the surgery or not. It's tough to say. This slide here is just showing the pathologic features, showing a higher preponderance for open, higher grade tumors or stage tumors in the open partial nephrectomy group, and a reduction in the positive margin rates for open versus laparoscopic and robotic, and less positive margins in lap compared to robotic as well. Doing univariate and multivariate analysis, overall complications for open partial nephrectomy was higher, as can be expected, as was transfusion rates, and the transfusion rates for laparoscopic surgery was higher than for robotic. Another systematic review focusing solely on laparoscopic versus robotic partial nephrectomy. This was done in 2015, published in European Urology. This included 23 studies, 4 of which prospective, 18 retrospective, and 1 was unclear what the study design was, which I'm not sure why it was included. But in any event, this showed that the conversion rates either to an open surgery or to a radical nephrectomy favored robotic surgery with no difference in complications. Warm ischemia time and GFR change seemed to favor robotic surgery over laparoscopic as well, but no change in operative time or creatinine decrease. So kind of 2 contradicting results there with the GFR decrease, but anyways, that's the results. Length of stay was also slightly shorter in the robotic surgery compared to the laparoscopic. No difference in blood loss or margins. So overall, kind of as expected with open surgery leading to more complications, possibly higher blood loss and longer hospital admissions, and robotic and laparoscopic are comparable, but maybe a slight advantage to robotic. So in terms of specific steps, there's multiple pieces. Once you have the kidney dissected, where surgeon preference really takes over in regards to Hilar control, how they resect the tumor, whether they perform Renorrhaphy in 1 or 2 layers, as well as the type of sutures that they used and clips that they may apply to these different sutures. So for Hilar control, different techniques are an en bloc clamping, selective arterial clamping, super selective arterial clamping, getting into the segmental arteries. Some people will do off clamp if the tumor is amenable, and then there's early off clamping as well, where you test your first layer of Renorrhaphy or your kind of off clamp resection bed to see whether or not additional adjuncts are needed. So in this study, this was done back in 2015, looked at selective arterial clamping versus Hilar clamping. So this is only clamping the main renal artery. And it's a systematic review of 7 retrospective studies looking at MIS partials. They did find that there was increased estimated blood loss and operative time in the selective clamping, but there was no difference in the number of blood transfusions. They said that there was better renal function at 1 week and 3 months post-op. And 2 of the studies looked at 6-month follow-up, which showed no difference in the change in GFR, but still kind of unclear which is best, the en bloc versus renal artery only. This was a paper in 2014 looking at superselective arterial clamping, so trying to get closer to the renal tumor to preserve blood flow to the normal parenchyma. This was a retrospective comparison. This one basically showed that the warm ischemia time was improved in the superselective group, which is mainly due to the fact that they noted warm ischemia time as 0, as they said that there was no residual parenchyma that was left with ischemia. Operative time was longer in the superselective group because you had to chase these arteries into the renal sinus a bit. There was no difference in intraoperative complications, no conversions from partial to radical, and no conversions from robotic to open. Perioperative transfusions did increase in the superselective group. Interestingly, there was an 50 patients, or 86% of the superselective clamp group did require collecting system repair. So quite significant, in my opinion. Overall, the patients that did require blood transfusions patients who required blood transfusion tended to have more comorbidities on the indexes that they looked at, and had lower preoperative hemoglobin overall compared to the average of the group. So this was just to mention that there was no difference in positive margins between the 2 groups, the superselective or the selective. In terms of renal function change, it did seem to improve or at least favor the super selective clamping group at postoperative follow-up. And there was no difference between the two groups in terms of baseline renal function. So if we can kind of keep working further towards the tumor to preserve blood flow to the renal parenchyma, what if we don't use a clamp at all? This was a Italian study that looked at propensity score matched comparators between two groups on or off clamp during the partial nephrectomy. So this was during laparoscopic surgery. They found that the mean warm ischemic time obviously was less in the off clamp group, and mean EGFR at last follow-up was improved in the off clamp group. This was a portion of their study where they were looking at predictors of leading to chronic kidney disease, stage 3 or greater. And they found that the predictors for reduced GFR stage 3 CKD was what their discharge GFR was, and whether or not they had an on or off clamp partial nephrectomy was also predictive for long-term CKD. So once we've got the hilum figured out, then we have to figure out how we're going to cut the tumor out. So looking at different resection techniques, this study from 2020 looked at whether or not people were doing enucleation of renal tumors, enucleal resection, or clean resection of the renal tumors. They looked at 507 patients, and these patients had T1 or T2 tumors. 48 different surgeons were analyzed internationally, and all three approaches, open, laparoscopic, and robotic, were included. Exclusion criteria was solitary kidney, multifocal tumor, or bilateral tumors, just to remove any bias from the surgeons. They assessed margins, complications, and postoperative AKIs. Overall, their positive margin rates were somewhat higher than you'd see in other literature, with enucleation having a 4.9% positive margin, enucleal resection at 10%, and clean resection at 2.2%. Multivariable analysis in this study showed enucleal resection was worse than both enucleation and resection. In this study, they didn't look at sort of the surgeon preoperative approach, whether they were going to enucleate or resect the tumor. So it may have been a point where intraoperatively, they started enucleating and then got into trouble and had to start resecting to get wider margins. So that may be an account for why the enuclear resection group does have higher positive margin rates. So once the tumor's out, then we got to close the hole. With Renorrhaphy, there's 110 different ways to do it. Closure of the collecting system is imperative to avoid any urinomas or urinary fistulas. Preserving blood flow, obviously, is key after we've just spent the time to resect the tumor delicately, leaving the main vascular structures intact. And always got to keep in mind that a nephron-sparing surgery needs a nephron-sparing Renorrhaphy. So taking big bites of your resection bed may not always be the best thing overall, although it may stop the bleeding. Just a reminder of the renal blood flow anatomy, with the renal artery leading into segmental branches, interlobar arteries, arcuate arteries, and then the interlobar arterioles. So these are the smaller parenchymal perforators. And usually these kind of interlobar arteries, if you accommodate one of these into your primary or first layer closure, you can really affect the perfusion to more than just your resection area, knocking off kind of an extra 5-10% of a kidney. So this was a meta-analysis or systematic review of 86 studies looking at single versus double layer Renorrhaphy and whether or not it was running or interrupted. They also analyzed barbed versus unbarbed suture, which we'll talk about a little bit later in the presentation. The outcomes that they looked at were warm ischemic time, operative time, estimated blood loss, complication rates, and fistulas. Unfortunately, there was no GFR outcomes that were included in this study, I guess just due to the variability in the 86 studies that were included. So overall, between single layer and double layer, it seemed to favor single layer closure of the resection defect in terms of operating time and ischemic time, which kind of makes sense. There was no difference in blood loss between the two groups. There was also no change in postoperative complications or fistula formation between 1 or 2 layer closure. In terms of, they also looked at running versus interrupted sutures. Again, running tended to favor lower operating times and lower ischemic times. So you're not, spending the time tying the knots, bringing in the scissors and that kind of thing during laparoscopic surgery. No difference in blood loss. There was also lower postoperative complications and less blood transfusions in the running suture group versus interrupted. And I don't know if anybody here in BC is doing interrupted sutures for their first layer Renorrhaphy. But anyways, it clearly favors a running stitch. This is another systematic review assessing 6 articles only. 3 articles were looking at running versus interrupted and 3 looking at single versus double layer closure. Again, interrupted suture didn't show any benefit compared to running. And single versus double layer, there was a preponderance or the groups favored a single layer suture, as the double layered suture favored the preoperative GFR. So a single layer preserved more nephrons than doing a double layer. So what about in robotic surgery? This was an odd non-systematic review. We're getting into the kind of not so good evidence here, but 3 retrospective studies were included for this robotic retrospective study with 1 versus 2 layer Renorrhaphy assessed. And they looked at volume decrease or renogram results to assess their renal function. So not the best metrics to look at, but in any event, it did show that a single layer did improve GFR or had less reduction in GFR compared to a double layer. And the ipsilateral split renal function decrease favored a single layer as well. So
Drew, does that mean you're not running the bed if you're doing single layer, or
single layer is just the kind of deep stitch. The second layer is the cortical stitches.
So if people are doing single layer, they're just doing the deep stitches and not doing the cortical stitches?
Correct. Yeah. So if we can get away with 1 suture layer, what about no suture layers? Is there any possibility of not suturing at all? This was a kind of proof of principle, or how I do it, paper on 102 patients, where they looked at, they used flow seal as a hemostasis tactic, where after their resection, they would put 5 cc's of flow seal on the resection bed and apply pressure for 5 minutes. And then they would remove everything and unclamp and then see what happened. They noted estimated blood loss on average was 180 cc's roughly. And the change in pre and post-op hemoglobin was only about 10 points difference. Interestingly, they had 36% collecting system entry, which required repair. So they did have some suturing of the base in this study, 36% of the patients. Overall, you can see that the tumors were fairly low stage, with T1 tumors making up the majority of the cohort that they looked at. But they had pretty good results with only 2 patients requiring reoperation. One had an infected hematoma, and one needed reoperation for instability, but no bleeding was seen at the resection bed. So an interesting.
So Drew, how is that possible? How can you not sew anything and just put on some flow seal? Is that something you're going to try as soon as you're done residency? It seems crazy to me.
It seems crazy to me, but I'm just the messenger. So it didn't seem like they had any kind of stratification or complexity analysis in this report. So whether it was totally exophytic tumors only that they included, they didn't mention. But yeah, I agree. I wouldn't be doing this on my own. And you'll see later that there's really not much evidence for or against clotting factors in partial nephrectomy, because it's really hard to recruit patients for, if you're trying to randomize a group between we're going to use things to help your blood clot or not, people are going to say, no, I want the blood clotting factors, right? So accrual for those studies is pretty abysmal.
Maybe they left the bulldogs on at the end of the case.
It could be. Although, yeah, those patients didn't get reoperated on, they said.
We've got the Dr. Blacker product at home from Baxter, Hemopatch. I'm not sure it's here, but that they certainly argue that you can use that solely if you've closed the collecting system injury and it's got sort of cellulose and then some clotting factors, but you actually leave it on, it sort of forms this gelatinous sort of goo, and you apply pressure for a couple of minutes. And yeah, from an anecdotal thing, seen it done 2 or 3 times, it's useful for those sort of like a lower pole heminephrectomy or something where you haven't got much that you can fold over or bring together for your renorrhaphy. I agree. I'd always choose to sew if I can, for that reassurance, but the company has to do it.
The other thing you can potentially do is actually, if you go slow when you're resecting the tumor, is that you can see vessels and even clip individual vessels. And so I can imagine if they're doing something like that, but it doesn't sound like they were.
Yeah, no, not from their description. I mean, yeah, maybe they did on one patient or something, but wasn't reported. This was another meta-analysis of retrospective studies comparing sutureless versus a sutured partial nephrectomy. 8 studies included. They were all laparoscopic. 7 used electrocautery at the resection bed, and 7 used biohemostatic agents. There was 1 study that used biohemostatic agents only, and 1 that used electrocautery only. Interestingly, the sutureless technique seemed to favor tumors of higher renal complexity scores, which I was not expecting to see. And there was no difference for lower renal complexity scores, which may be indicative that there may have been some selection bias for these groups. There was no difference in terms of postoperative complications or positive surgical margins between the groups either. Tumor recurrence and postoperative GFR, there was no change. So I think there's something going on with the data here, because if you're not suturing the base, you would expect that there would be improved renal function post-op, but this meta-analysis didn't seem to show that. So what about suture type? Everybody has a different suture type or suture technique for the Renorrhaphy that they like to use. This was a master's thesis, a bit of gray literature here of a guy from Grand Valley State University. He looked at he was in the engineering department, and he was looking at the amount of force that you could apply to different suture bolstering techniques before there was capsular violation or suture failure. So you can see the kind of newtons of force that could be applied to different techniques here. 7.3 newtons for a laparoscopic with no knot, 22 newtons for a hemalock with a knot. A hemalock only on a suture gave 3.4 newtons worth of force before failure, and 10.6 if you use two hemolocks side by side. A lapra with a knot increased the strength of holding as well. He used a PDS suture for this study, and of note, a single knot alone on the kidney only gave 2.7 newtons worth of force before it pulled through. He also looked at what kind of the holding strength of these clips is with various different types of sutures. Interestingly, the Vicryl suture had the least amount of holding strength amongst all the sutures that he tested across all suture sizes. And the V-lock suture seemed to have kind of the highest holding strength across all the sizes.
So, Drew, do we have any idea what holding strength we need?
Was not looked at here. This was ex vivo. It would be interesting to see kind of, it would depend obviously on the size of vessel that you're getting into. But we've seen that Vicryl seems to do okay for the base layer suturing. But I'll show you kind of the duration of how long that'll last here in a second. That was his second study in his thesis. This was the device that he used to look at kind of the length of time that a 4 Newton strength could be applied to different types of sutures. So this is basically a water bath here. And these are all springs hooked up to monitors up on the top. And it was warmed to 37 degrees Celsius. And he just let the recorders do their thing and see how long the suture would last before it either broke or there was a slippage of the knot and bolstering apparatus. So the mean duration for Vicryl sutures, you can see here kind of in the middle, was somewhere around 500 hours at 4 Newtons of strength, which equates to 21 days almost before it failed. So, assuming we're putting at least 4 Newtons of strength, that'll last 500 hours or 21 days. Chromic actually was quite a bit longer, which surprised me. And then they did some kind of more PDS type sutures, which also didn't seem to hold their strength as much. But PDS wasn't actually included in this series. So going back to that study we mentioned earlier, the systematic review, where they were comparing 1 versus 2 layer, interrupted versus running. This was the third metric they were looking at in the review of just over 60 studies. Using a barbed suture like the V-lock that some people will use tended to favor lower operating times, less blood loss, and less ischemic time. So the people who were using these barbed sutures, they were doing it in a running fashion. So you kind of get the that effect layered on top of it as well. There was no difference in postoperative complications, fistula formation, or blood transfusion between barbed or unbarbed patients or sutures. This is another review of 8 cohort studies. 1 was a robot-assisted partial nephrectomy study. 5 were laparoscopic and 1 was open. 2 were open. The barbed sutures seemed to improve warm ischemic time, lower operative time, and less overall complications. There was no difference between the estimated blood loss or transfusion rates between the 2 groups, and no difference in hospital stay. Also in that meta-analysis, they looked at renal function, and although they weren't able to directly compare studies due to the follow-up times being different, they did notice that within each study, there was no comparable difference between the groups in terms of renal function. So again, with hemostatic agents, everybody uses something a little bit different, whether you use flow seal at the base over your first layer and then do the cortical stitches using bolsters, things like that. But like I mentioned, it's very hard to find studies recruiting patients to using hemostatic agents versus not, because most people tend to just want all of the clotting factors. which I don't blame them. But it seems to, maybe there is a way that we can use hemostatic agents with no suturing. Who knows? I think more studies need to be done. This was a group that interestingly combined in a hybrid room. They went to interventional radiology, or had interventional radiology join them in the operating theater, where they would use intra-arterial embolization to localize the segmental artery or subsegmental artery that was perforating the tumor, embolize it, and then carry out their partial nephrectomy. They did these partials with no Hilar clamping and no Renorrhaphy, unless they got into the collecting system. They looked at 137 patients, but they did have more recruited into the study, although 44 had solitary kidneys, and 28 patients had no postoperative scans. 12 had solitary kidneys, 28 had no post-op scans to compare. This is just a schematic of the preoperative angiogram showing this kind of vessel perforating down into the lower pole renal tumor here. Here's the post-embolization film showing no filling of this portion of the kidney, indicating ischemia achieved, and then comparative CT scans preoperatively showing this partially exophytic lower pole tumor preoperatively, and then postoperatively, and you can see the embolization coil there with a resection defect. They followed these patients up for 6 months, and they did show a decrease in GFR as expected after partial nephrectomy. The difference in GFR was about 10 points, which was significant. Although they kind of described significant renal function loss as a change in 25% of renal function. And we'll talk about that over here. There was only one patient who had a new chronic kidney disease diagnosis at 6-month follow-up, and 4 patients had pre-existing CKD. This is just looking at the volume loss, which showed there was a statistically significant amount of renal volume lost, which makes sense because they were cutting it out. The only thing that seemed to predict a less than 25% or greater than 25% loss in renal function was age at the time of surgery. The complexity of the renal tumor, estimated blood loss, and whether they embolized 1, 2 arteries, used more contrast or not, didn't seem to affect their long-term outcomes or putting a signal towards more significant renal loss. But an interesting tactic nonetheless. They said there was no postoperative bleeding, transfusions, or complications from these patients. They did not need to clamp the hilum, and that was kind of shocking to hear. One thing that they didn't mention, but was the positive margin rates. But I was thinking, maybe positive margins wouldn't matter so much if you've already embolized and made that tissue ischemic. I'm not sure. But they didn't look at long-term follow-up for recurrence in this study, but it would be interesting to know. So where can we go from here in terms of the partial nephrectomy? How can we improve on an operation that's done fairly routinely? A recent AUA update series discussed kind of 3D printing of kidney tumors. I think this is pretty interesting in terms of teaching and preoperative warm-up for surgeons. If there's a high complexity renal score that's very medial, close to the hilum, or going to be a significant amount of kidney, or a patient that's very high risk for renal deterioration postoperatively or requiring dialysis, you can basically map out the kidney and the tumor on the CT scan, reconstruct it 3-dimensionally in a computer program, and then 3D print this beautiful replica of the kidney. I'm not sure what kind of materials this is, but I'm sure that, as technology improves, we could make this in something that's a little bit gelatinous or something to practice resection and suturing to try to avoid these blood vessels and collecting system before actually doing it in the patient, which would be great for resident learning as well as surgeon practice if it's a high-risk patient. I couldn't find any literature on organoids or, biologic 3D printing, but there are people that are looking at this with skeletonizing the kidney into its main collagen structure, and then kind of redeploying stem cells to regenerate into renal tissue. This is something that's ongoing, but would be pretty interesting and even better probably for practice, but I think it's a little bit far off. And who knows, we may be able to, instead of putting flow seal on the resection bed, maybe we can spray some stem cells on there to regenerate the kidney that we just cut out. So more to come on that. This is a technology using near infrared light and a labeled marker that's given intravenously. These are laparoscopic images here of a tumor up in this kind of upper portion of the screen, with normal parenchyma down here. They inject a contrast, or not contrast, but a tracer, and then shine near infrared light, and it basically illuminates the portion of the renal parenchyma that's healthy. So it'll give you a good idea visually of where the margin is, where at least where you need to start resecting. So this is sort of a helpful adjunct that might be useful in resecting tumors laparoscopically or even robotically. This is another shot using that same technology, but aimed at the blood vessels. So you can actually see the renal artery here and renal vein here. And this is the image here with no, the lights are still on here. So renal vein and renal artery. And you can see this little segmental branch here, which they were able to put a clip on, a bulldog clip. Here's after the clip was applied, renal tumors here. And again, you can see that there's no lighting up of this tumor after clamping that segmental artery. So may be helpful for those kind of super selective clamping on a solitary kidney or something like that.
Do we have that capability with our robot or not?
I think it's just a matter of getting whatever they do inject a material. I can't remember what it's called.
Indocyanin green is the injection. I think we could do it on our version on the SI robot, yes, but the reagent is expensive.
So it's Firefly, right? Yeah. Okay.
Yeah,
cool.
Firefly. That's what it was. Yeah. So yeah, I think it's quite expensive, and I'm not sure there's been any large scale studies on it for partial nephrectomy, but something that could be interesting. One more tool in the toolbox. This is an interesting technology. I'm not sure where this one was developed, but it's basically 3D rendering of a kidney with the collecting system and vascular structures based on preoperative CT scan. You can see here the collecting system in yellow and the tumor in this kind of gray color. Here's a intraoperative image. And you can overlay that 3D reconstruction after you've kind of marked out the margins of your kidney with this kind of triangular hexagonal kind of 3D rendering program here that is built into the robot, and you can actually see in real time as you're working on the kidney where the tumor is in relation to the collecting system and blood vessels. So this is a really interesting technology that in real time can kind of track your kidney and help you out without obstructing your vision too much doing the actual surgery. This is a similar but slightly different and less intensive program that you plug into the robot, and there's a 3D reconstruction based on the CT scan, and the surgeon can rotate and manipulate the rendering down here to kind of match out with the lay of the kidney in real time here. So in the circle, you can see the renal hilum highlighted, and this kind of correlates to this little branch shooting off here with this branch coming up over that kind of segmental vein there. So it does give you a roadmap and kind of help you when you're dissecting through, especially that kind of adherent fat that we hate so much, to help kind of make sure that we preserve blood flow to the healthy parenchyma. Here's another different type of rendering with the tumor highlighted in green here. So again, it can give you a bit of a roadmap to where you need to cut. So that's all that I had prepared for you guys today. Happy to take any questions, and yeah, thanks for your time.